It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. I know some of you guys are getting ready for your boards and are hopefully still enjoying your summer. We have ultrasound courses coming up in New York, Costa Rica, as well as we do private sessions. Just check out the nrappain.org and go to the ultrasound or CME calendar and get more information. The conference is coming up. I'll be speaking at Pain Week, doing a review of ultrasound in the pain practice as well as PRP, and then presenting at a primary care conference in London on the same week as ISPN, in which I'll be teaching ultrasound at ISPN. So that should be a lot of fun. Hope to see you guys there. And if you're studying for the board, sign up for painexam.com, which is actually at the NRAP website, and you'll get access to the forum where we post recently asked keywords. It might guide your studying, see what might be missed in some of the reviews out there, as well as you could sign up for the virtual pain fellowship, which is basically the board prep plus online ultrasound and regenerative medicine training. So that's nrappain.org. Anyway, I found an interesting article here, Ketorolac injections for musculoskeletal conditions, a narrative review. I'll have the reference in the show notes. And just to review, Ketorolac is a NSAID that provides analgesic and anti-inflammatory mechanism actions through peripheral inhibition of prostaglandin synthesis from non-selective cyclooxygenase inhibition activity. The medication is approved for oral, intramuscular, and IV use. It's also topically available. Off-label subcutaneous use has been described. Common drug alternatives to Ketorolac injections for musculoskeletal diseases are corticosteroids and various formulations of hyaluronic acid. Corticosteroids are commonly injected both intra-articularly and extra-articularly. Their mechanism of action is somewhat complex, with the effects on the immune and inflammatory cascade at multiple levels. The injection of the corticosteroid can inhibit phagocytosis, neutrophil superoxide production, metalloprotease activator, and prevent synthesis of inflammatory mediators such as prostaglandin and leukotrienes. Unfortunately, these corticosteroids do have side effects such as insulin resistance by glucose transporter type 4, which could lead to hyperglycemia from the steroid. Hyaluronic acid can provide proteoglycan and glycosaminoglycan synthesis and mechanical subconjugal analgesic and anti-inflammatory effects through the CD44 mediated actions. Back to Ketorolac, the plasma half-life is about 5.2 to 5.56 hours. And this is independent of route of administration and dose. The half-life is greatly impacted in patients with chronic renal disease, but is not affected by hepatic impairment. The bioavailability in adults following oral, intramuscular, and IV administration is estimated at 87%. However, pharmacokinetic properties of Ketorolac delivered subcutaneously are not as clearly defined in the literature. It's metabolized through glucuronidation and hydroxylation in the liver, with metabolic products excreted in the urine. Pregnancy and lactation also impact pharmacokinetic characteristics of this drug. Fetal risk in pregnancy cannot be ruled out, and infant risk has been demonstrated in breastfeeding. But there's really no data available on the pharmacokinetics of intra-articular Ketorolac administration, which is where this article gets interesting. So subacromial conditions, shoulder, right? Subacromial impingement is about 50% of most shoulder complaints. It's includes rotator cuff tendinopathy, subacromial impingement, and subacromial bursopathy. The pain and restriction range of motions lead to disability and decreased quality of life. The irritation of the bursa against subacromial arch is a common feature. Treatment is usually conservative, and subacromial bursa injections are commonly used. Goyal et al. Performed a randomized controlled study of 35 patients who received subacromial injections with 60 milligrams of ketorolac and 2% lidocaine, with the control arm receiving 40 milligrams of methylprednisolone, 2% lidocaine. Both groups improved statistically significant in VAS and disability index scores. No differences were found in functional outcomes at either group. Tahiri et al. Randomized 40 patients into two groups receiving either 40 milligrams of methylprednisolone or 60 milligrams of ketorolac as a subacromial injection along with lidocaine. At 1 and 3 month follow-ups, both groups had statistically significant reductions in VAS scores. However, no differences were found between the groups, suggesting both drugs were equally effective in relieving pain. Kim et al. Randomized 60 patients with rotator cuff syndrome in two groups. One received one mixture of triamcinolone, 40 milligrams per ml, and 1 milliliter of lidocaine, 2%, while the other received 1 milliliter of ketorolac, 30 milligrams per ml, and 1 milliliter of lidocaine, 2%. Both groups had similar clinical improvement at 3, 6, and 12 weeks after the procedure, with no significant differences in outcomes. Min et al. Randomized 32 patients with shoulder impingement, and they found similar results. Actually, greater improvement in the ketorolac group, and in the UCLA shoulder rating scale in forward flexion and patient satisfaction. No difference were seen in other outcome measures. So in that group, it was 40 milligrams triamcinolone versus 60 milligrams of ketorolac subacromial. How about glenohumeral joint conditions such as adhesive capsulitis or the frozen shoulder, which is immobility of the shoulder? That could be primary, idiopathic, or secondary following trauma. This is usually treated with medications, physical therapies, injections, steroids, nerve blocks, etc. Here, ACTAR randomized 160 patients with the adhesive capsulitis receiving intra-articular injections of either 60 milligrams of ketorolac and 6 mLs of lidocaine 1% with epinephrine, 8 mLs total, versus 4 mLs of 1% hyaluronic acid and 6 mLs lidocaine with epi. They found decreased pain score in the group with the ketorolac. So why aren't we doing this routinely? I'm just wondering. Anyway, An et al. Performed prospective trials of adhesive capsulitis comparing intra-articular injections of 4 mLs of 0.5% lidocaine with triamcinolone to 19 mLs of lidocaine, 0.5% with 30 milligrams of ketorolac. Now I see 19 mLs is like hydrodilation or distension. It seems like all injections were administered under ultrasound with the goal of achieving the capsular distension. Then they did 2 additional injections at 2-week intervals until reduction in self-reported pain was 50% or more. Follow-up to evaluate were conducted at 1, 3, and 6 months. The authors did not find any difference between the groups 1, 3, and 6. Furthermore, they found superior mobility, passive external rotation in the ketorolac injection group compared to the corticosteroid group at 3 and 6 months. Just anecdotally, I wonder if you just did compare these with lidocaine alone, because I'm sure that could be beneficial. They also have a study here of the carpal-metacarpal joint where they did for osteoarthritis. They did 38 patients, 0.5 mLs hyaluronic acid and ketorolac, and the other 36 just hyaluronic acid alone. At 1 month, the onset of pain relief was remarkable quicker in those who received the ketorolac. Movement limitation and verbal numeric scales were measured at 1, 3, and 6 months after the injection. No significant differences were reported. Overall study indicates that ketorolac's quick onset of action, pain relief, was key to adding the medication in the intra-articular injection. Hip and knees as well. They looked at it was a retrospective view of hip arthritis, ketorolac versus steroid. 1, 3, and 6 months, they looked at the Harris hip score and verbal numeric pain scores. No statistically significant differences observed between the groups, suggesting intra-articular ketorolac is as effective as intra-articular corticosteroids in the treatment of osteoarthritis of the hip. Wow, that's interesting because none of us are really doing this, at least not the colleagues I have. Most of us are not doing this, so it's kind of interesting. Jungzamir and colleagues conducted a double-blind randomized controlled trial of 110 patients with moderate or severe primary arthritis of the hip to either receiving intra-articular Ketorolac versus one intra-articular triamcinolone injection. At 1 and 3 months, they measured. There was no, and once again, no statistically significant differences produced. And you could read this article yourself. It kind of goes on and on. They talk about the safety as well of Ketorolac. Well, it's limited by gastrointestinal hematologic side effects as well as renal side effects. Reduced platelet aggregation is associated with a decline in renal function. Rare but serious renal adverse effects include kidney injury, nephrotic syndrome, renal failure, tubular interstitial nephritis. The advent of soluble and injectable NSAIDs has offered the potential advantage of delivering these type of anti-inflammatory agents to local sites of inflammatory process, enable physicians to bypass the GI tract, so you might be less likely to get GI irritation. The limitations, well, it may not be right for all patients. Those who have renal, gastrointestinal, cardiovascular disease, you may want to limit or not use it. Higher risk of hypertension and cerebrovascular cardiac disease, there could be an increased risk. And NSAIDs are the most common cause of drug-induced hypersensitivity reactions, and clinicians should give special consideration to patients with asthma, nasal polyps, and chronic urticaria, where the hypersensitivity may be as high as about 30%. So in conclusion, intra-articular or intrabursal Ketorolac injection may be a safe, efficacious, cost-effective alternative to steroids or other forms of conservative management for treatment of musculoskeletal conditions. Although the number of studies evaluating Ketorolac injections are limited, its efficacy has been demonstrated in subacromial bursopathy, adhesive capsulitis, first carpal-metacarpal joint and hip and knee osteoarthritis. While the safety profile of intra-articular Ketorolac is not well described in the literature, the localized chondrotoxicity and systemic effects of intra-articular steroids make Ketorolac an appealing alternative. Further studies are warranted to better understand the intra-articular effects of Ketorolac in management of musculoskeletal conditions. Well, I'm going to be honest here. I'm not, I have thought about that patient who sees you for the first time, begs you for an injection, but you're not authorized, so you do like a Ketorolac injection intramuscular. Well, maybe you just slide it into the bursa. I mean, it's not that much, it's not that harder. I mean, or you actually put the Ketorolac where the pain problem is, which is something I haven't been doing, but perhaps I should be. Like that patient who has even a low back muscle spasm, I'm typically not putting the Ketorolac into the spasm. I'm putting it like into the shoulder or something and waiting to get authorization, or just doing a trigger point of lidocaine into the spasm. But should I be mixing the Ketorolac with the lidocaine and putting it into that localized muscle or joint or area that's hurting the patient? Well, according to this article, we should consider it. Definitely need more evidence to make this a standard of care type of thing. But very interesting article. Kudos to the authors. Guys, if you're interested in doing some more training with me, check out nrappain.org or sign up for my newsletter. We do have courses going on almost every month, as well as private courses can be arranged, or just see me at the conferences that I teach at. I forgot to mention earlier, LAPS is coming up as well. That's a great conference in Chile. I won't make it this year, but Dr. Dewan is amazing, and he puts on a great conference. So hopefully you guys could check it out. If you didn't go to Aspen, it was great. ISPN is the next one after Pain Week. So hope to see you guys in September or October at the conferences. Thanks for listening. Please review the podcast if you like what I say, and share it with your colleagues. Much appreciated. Thank you. Have a great day.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.